Welcome to my workplace at Ranaghat, West Bengal, India. This patient is a 70 years old lady who presented with high intraocular pressure, vomiting and left-sided headache, circumciliary congestion, a flat anterior chamber, and a mature intumescent cataract. So this is a case of Phacomorphic glaucoma. Intravenous mannitol was administered. Intraocular pressure, which was in the range of 60 mm of mercury, came down to 40 mm of mercury, and I took up the case under peribulbar anesthesia. And peribulbar injection produced this subconjunctival haematoma. So a lot of challenges in this case. The antechamber is flat, so I could not inject an air bubble. Without air bubble, I injected the anterior capsule with trypan blue dye as much as possible. And now I am injecting Visco 2% HPMC. Now since I administered mannitol 20% mannitol intravenous 1 hour before surgery, the antechamber formed because of this administration of 2% HPMC into the anterior chamber, and I could get some space to work. So I have incised the anterior capsule, and now I am making a small rhexis, because in intumescent cataracts, if we try to do a large rhexis at on-go, most of the time the rhexis will run to periphery. So this is my routine. I make a very small rhexis, aspirate some lens matter through this small opening, and reduce the intralenticular pressure. This maneuvers forms the anterior chamber, and it becomes possible to work in the anterior chamber. And now with the help of a Vanna scissor, I am making a cut here at around 7 o'clock, taking the ureter again, and now I have some working space. And with the help of this ureter, I am enlarging this small rhexis and trying to make a large rhexis or adequate sized rhexis. Here we must not leave and try to complete just in front of the main incision. We must not leave the tag. Just cross this area and go anteriorly and try to complete the rhexis. And now I thought the cataract will not be so hard. If I could assess, I could have made a crater and then start chopping, but without that I tried to chop the nucleus and just I made a scratch. Could not crack these nucleus, it is so hard. And so I just rotated the nucleus, went to a deeper aspect and made a deep crack. Rotated it and held it at another place and made another crack. In this way I am making some cracks. I am in Phaco 2 mode from the very beginning, where the vacuum is 450 mm of mercury, flow rate is 45 ml per minute, and ultrasonic energy is about 80%. Here I edited out some portion. I just did some sculpting and made a pit at the central area, and now I am trying to break the leathery plate which is keeping all the fragments joined to each other. So what I am planning is, I can see a very small gap just in front of the main incision, injecting some visco through it. I have taken a very much blunt instrument, going through this gap and lifting it up. And now with the help of this sense key, I am breaking this leathery plate. Yes. And now the case is almost conquered. So if you find a leathery plate holding all the fragments together, find out a gap somewhere, introduce a blunt instrument through this, tent the leathery plate up, and just break it with another instrument like a Sinskey hook or your chopper. Now this fragment I'm not able to bring it towards center because it is joined to the another fragment on the right side. So this fragment is free and I can emulsify this piece, the piece which is just underneath the sideboard. And now here I apply some energy and divide these two pieces, and now it will be easier to emulsify these pieces. Ultrasonic energy being used is 80%, flow rate is 45 ml per minute. It can be from 35 to 45, anywhere between that, and vacuum is 450. It can be 350 to 450. And now these are the last bits of the nucleus. At this time I have removed the chopper from the anterior chamber, and I'm just doing emulsifying the pieces single-handedly so that I get a very stable chamber. And now in this case the very minimal cortical matter was there, almost no cortex. So I just used a Simcoe. This is, you can see just in front of the sideboard. This is a very small bit of nucleus. We must remove this small bit first, otherwise it may get lost somewhere behind the iris. So remove any small nuclear bits first, and then remove the cortical matter if it is there. In this case there was no cortex anywhere. And now I inject visco, fill up the anterior chamber and capsular bag, and implant a hydrophilic acrylic single piece monofocal intraocular lens. All these patients are usually from low socioeconomic category. They cannot afford hydrophobic lenses which are costlier, so we have to do these surgeries in India with hydrophilic lenses. And though we spend a lot of time in doing such cases, we don't get paid that much. So just for our satisfaction and the satisfaction of doing some challenging cases, the satisfaction of overcoming challenges, we can do these kind of surgeries. In this way we can improve ourselves. I remember a quote of Jim Rohn where he said, "Wish not it were easier, wish you were better. Don't wish for less problems, wish for more skills. Don't wish for less challenges, wish for more wisdom." Beautiful quote. I always keep this quote of Jim Rohn in my mind. Whenever I find a challenging case, I try to raise myself at a higher level and overcome that challenge with a lot of bravery. And now, after hydrating the side ports, form the anterior chamber very nicely, and in this case I have injected some moxifloxacin like this, so that I hydrate the main incision as well as some moxifloxacin goes inside. This is a drop of HPMC to keep the surface lubricated. These are some post-op pictures after 7 days. Cornea is clear, anterior chamber is quiet, pupil is round, intraocular pressure, which was 52 mm of mercury preoperatively, is now 14 mm of mercury without any anti-glaucoma medication. Visual acuity is 6/18. A very satisfactory outcome. Thank you very much for your attention. Hope this video will inspire you to take up challenging cases.